replacement, I expect his pulmonary hypertension to be corrected. But having pulmonary hypertension that too severe, I think there is some other issue going on equally, which is contributing. So I want to look into other causes which are contributing to his severe pulmonary hypertension and leading to his symptoms. Explaining alone with the acute MI and LV dysfunction seems to be unusual for me.
Okay, perfect. So you would explore his lungs more, I would guess.
Yeah.
Okay, okay. Would you do a right heart cath on this patient at this time?
Yes. Yes. So I'm tempted to do right heart catheter in him.
Okay, all right. So this is all our guesswork. This is what most of us in some form or the other do. So we'll have expert opinion and then we'll open it for discussion for rest of the audience. So Dr. Shastri, if I could have you here and get your opinion, how would you approach this?
Yeah, first of all, thank you very much, Dr. Anup, for inviting me to be the guest here. And this is not an uncommon patient that we have got. 73-year-old male with anteval myocardial infarction, severe MR, post-surgery, severe dysfunction, normal functioning prosthetic valve, and severe PAH. PAH here appears to be disproportionate than you expect. That's what Pranit was hinting. Generally, following mitral replacements of a severe MR, we may expect a lower pH. So, as you rightly said in the beginning, Brownwald or any textbook on pulmonary hypertension or article on pulmonary hypertension deals with the different causes of pulmonary hypertension. And we have to have clarity what kind of pulmonary hypertension that we are dealing with. It can be in terms of the idiopathic and natural history. That is the typical classification that we see, 5 groups. Group 1 pulmonary arterial hypertension, idiopathic and associated pulmonary hypertension. Group 2 due to left heart disease. Group 3 due to thromboembolic pulmonary hypertension. Sorry, Group 3 due to pulmonary diseases, and Group 4 due to obstructive pulmonary vascular disease because of thromboemboli, etc. And Group 5 is unknown or multiple etiologies. These are not watertight compartments. What Dr. Praneeth was hinting, whether this particular patient has pre-existing lung disease or thromboembolic pulmonary hypertension are very pertinent valid points. So it is important because especially you are not expecting such severe pulmonary hypertension. It is important to go through the history and look at any pulmonary cause and see, and if there is any chronic obstructive airway disease. Was the patient a smoker? Did they have any history of chronic bronchitis, emphysema? So these pulmonary diseases can independently contribute to pulmonary hypertension, which you may wrongly be attributing to underlying left heart disease and valvular regurgitation. Similarly, patient who had got heart failure by the time he had surgery may have had a small emboli. It is not necessary that the typical pulmonary emboli that we see in the clinical practice where you see massive or submassive pulmonary emboli. In these patients, we may find small segmental artery emboli here and there, which may add to the pulmonary hypertension. And it is, so this may be actually a combination of underlying pulmonary disease because of the left heart disease, because of the valvular regurgitation, and also because of the pulmonary emboli, which are not detected clinically. And actually, if you look at the thromboembolic pulmonary hypertension, there are many patients who don't have a documented pulmonary hypertension, documented pulmonary embolism. So that requires to be looked at. And we have to investigate to understand that point. And coming to mitral regurgitation, in all probability, it may be secondary to the myocardial infarction. And anteromyocardial infarction does produce severe MR. Actually, that the mitral regurgitation produced by anteval myocardial infarction is far worse than the inferior myocardial infarction, or equally worse. I don't say far worse, equally worse. And any ejection fraction with severe mitral regurgitation, you have to reduce it further. LV dysfunction worsens after the mitral replacement. All this we know. And we assume that this mitral regurgitation is secondary to the myocardial infarction. And it is possible that the mitral regurgitation may not be related to the anteval infarction. It may be pre-existing moderate mitral regurgitation secondary to the mitral valve prolapse or some other structural abnormality of the mitral valve, and which got worsened due to anteval infarction. And in mitral regurgitation, typically pulmonary hypertension progresses over a period of years, it is possible that the patient had some pre-existing pulmonary hypertension which got worsened with all these events. So all these are possible. These are all from the etiological point of view. Now, trying to understand the pathophysiological point of view, one important thing, as you said, right heart catheterization. We have to have a right heart catheterization to understand whether it is post-capillary hypertension or pre-capillary hypertension. Hemodynamically, it is very important to understand what is the mechanism of pulmonary hypertension. Is it a passive transmission of the backward passive transmission of the wedge pressure? In any patient with severe left ventricular dysfunction, or any kind of cardiomyopathy, hypertrophic or restrictive cardiomyopathies, we expect increased left ventricular end diastolic pressure, which in turn increases the left atrial mean pressure, which in turn will increase the increased pulmonary wedge pressure. For the blood to circulate, pulmonary artery diastolic pressure has to be more than the pulmonary artery wedge pressure. As the pulmonary artery wedge pressure increases, pulmonary artery diastolic pressure increases, so does the pulmonary artery systolic pressure and the mean pressure. So whenever the pulmonary artery mean pressure exceeds 20 millimeters of mercury, we call it pulmonary hypertension. Earlier we were saying it is more than 25 millimeters. So basically, when the cause of pulmonary hypertension is the passive transmission of the venous pressure or left atrial hypertension more than 15 millimeters of mercury, we call it post-capillary pulmonary hypertension. Here the pathology is clearly after the distal to the pulmonary capillary vasculature. Now, there are certain diseases like idiopathic pulmonary hypertension or pulmonary hypertension associated with connective tissue disease or liver disease or HIV or any other Eisenmenger syndrome, etc., where the pathology is in the pulmonary arteries and arterioles. Here the pressure is generated, resistance, vascular resistance and pressure are generated in the arterial compartment, not the venous compartment. So pulmonary artery pressure, systolic pressure, mean pressure, diastolic pressure are elevated, but not the post-capillary pressure. The post-capillary pressure or the pulmonary capillary wedge pressure will remain less than 15 millimeters of mercury. And here there is a huge difference between pulmonary diastolic pressure and the wedge pressure. This difference between the diastolic pressure and the wedge pressure is called diastolic pressure gradient, and that is normally less than 3 or up to 3. If it is more than 7, we call it is predominant precapillary hypertension with normal pulmonary capillary wedge pressure. So to summarize, if in patient with pulmonary hypertension, if the pulmonary capillary wedge pressure is more than 15, we call it post-capillary pulmonary hypertension. If where the pulmonary vascular resistance is typically less than 3 Wood units. Whereas, if the pulmonary capillary wedge pressure is less than 15 millimeters of mercury and the pulmonary vascular resistance is more than 3 Wood unit, we call it precapillary pulmonary hypertension. In the recent past, maybe last few years, maybe last 1 or 2 decades, we have been seeing more and more cases of pre and post capillary pulmonary hypertension combined. Maybe we'll discuss about it later. But in this patient, you want to know, as Praneeth rightly pointed out, is it because of COPD? Is it because of thromboembolic pulmonary hypertension? Is it because of the mere left heart disease? It will be ideal to have right heart catheterization. But short of it, on echocardiography, there are a lot of pointers. In a typical precapillary pulmonary hypertension, which is dominant, you will have a RA-RV dilatation much more prominent. The interatrial septum will be pushed to the left side. The apex is formed by the RV, and the pulmonary flow acceleration time will be, of course, less than this one. The mid-systolic notch will be prominent in the precapillary pulmonary hypertension. And left ventricular filling pressures, the mitral Doppler, will show typical grade 2 or 3 pulmonary diastolic dysfunction. And LV interventricular septum will be contracting as part of the left ventricle rather than of right ventricle. In post-capillary hypertension, IVS forms still works as a part of left ventricle, whereas in pre-capillary hypertension, IVS tend to work as part of the right ventricle. So these are some of the clues, and there may be many more we'll discuss. All these point to the pre-capillary pulmonary hypertension. So looking at the echocardiography and also ECG. In the ECG, if you see dominant right ventricular forces, right ventricular hypertrophy, it tends to suggest a independent cause of pulmonary hypertension than post-capillary pulmonary hypertension or left ventricle. These are all important because Pranita has rightly pointed out, is it an additional pathology than pure left ventricular pathology, because such a severe degree of pulmonary systolic pressure is not expected in pure left heart disease. Now, there in the X-ray also, chest X-ray also, we can make difference. Does this patient have pulmonary venous hypertension, Kerley-B lines, bilateral pleural effusions, all these things, pulmonary congestion, pulmonary edema-like picture in the past, they would definitely favor left ventricular failure, which is more likely. A pulmonary algemia or signs of any thromboembolic pulmonary hypertension will suggest a thromboembolic pulmonary hypertension, though it is difficult to pick up the thromboembolic pulmonary hypertension on chest X-ray. Now, when you want to rule out the group 3 pulmonary hypertension, that is pulmonary, we have to discuss along with the pulmonologist and see what pulmonary function tests we can do in a sick patient like this. And sometimes even the diffusion capacity, which may not be the person dependent, may be helpful. And CT chest findings, if there is a pathology to suggest any chronic bronchitis or emphysema, these things may help. Now, to rule out thromboembolic pulmonary hypertension, the history of DVT or looking at D-dimer or looking at the deep vein thrombosis in the legs is not sufficient. If you really want to rule out, the best test is lung perfusion scan. Lung perfusion scan is more sensitive than CT pulmonary angiogram. And in a sick patient like this, where you may be afraid to give a lot of contrast load, you can do a VQ scan. In our setting, VQ scan is not available. We may do a lung perfusion SPECT CT, but it may not alter the treatment, because if you find some small emboli in the segmental arteries here and there, your treatment will be oral anticoagulants, and anyhow this patient has been receiving oral anticoagulants. Now, if you are sure that this patient, after the right heart catheterization, it is possible you may find pure post-capillary pulmonary hypertension or combined pre and post-capillary hypertension. It is very, very unlikely that this patient will have pure pre-capillary pulmonary hypertension. And post-capillary hypertension, just to tell you again, post-capillary pulmonary hypertension is when the pulmonary capillary wedge pressure is more than 15 millimeters of mercury with pulmonary vascular resistance less than 3 Wood units. And combined pre and post-capillary hypertension will be, pulmonary hypertension will be a wedge pressure more than 15 with a diastolic pressure gradient more than 7 millimeters of mercury and PVR more than 3 Wood units. So I think I'll stop here. Probably there'll be more questions. So we can discuss more about interpretation of the echocardiogram and the clinical management of this patient.
Thank you so much, sir. And I just would comment 2-3 things, and then we'll open it for discussion. So first of all, young guys, residents, whosoever are listening to this, you just heard an entire 1 hour pulmonary hypertension talk in 10 minutes. So I hope you are making notes. If you are not making notes, do remember to send you the recordings of this. When you are passionate about something that you do, then knowledge just keeps flowing naturally. And this is what you heard here. This is one of the beauty of not focusing on PowerPoint, because that way you can really just narrate what you think is going on. And I think we ran through, Dr. Shastry ran through pretty much the thought process of what you would do whenever you are talking about these kind of patients. So I'll open the discussion about the patient management and about any particular question that you have for Dr. Shastry or for amongst us related to this patient, because then we'll go to next clinical situation if we get time. So my question to the audience is, and anybody can take up and ask questions, that both Dr. Praneeth and Shastri sir said that we will do right heart cath on this patient. So this patient is planned for right heart cath. History-wise, he does not have history of smoking. His RV TAPSE is 14. I don't remember the measurements, but overall the measurement RV was not bad. IVC is around 1.8 centimeters. Others I again don't remember. So what else would you do for this patient in terms of investigations? His chest X-ray and CT scan, not HRCT, but regular CT scan, I'll tell you, he had left pleural effusion, which he was struggling since surgery. So he has a little bit of collapsed lung on the left side, which is there since that time. It kind of just sits there. Every CT scan, chest X-ray, you see some tiny bit of lung atelectatic collapse on the left side. But other than that, CT scan or chest X-ray doesn't have anything very pertinent. These all workup he has done already. Right heart cath we will plan as we discussed. Anything else you would like to do on this patient? And while you speak, you can also ask any questions that you may have. The floor is open for discussion. One of the question is, will the recording be shared? I will share it. Just email me if you want the recording to be shared. I'll email it back to you. Any suggestions? Anything that somebody would do differently for this patient? Would somebody like to put him on pulmonary vasodilators right away, like sildenafil or something like that? While people are thinking, Dr. Shastri, I'm going to ask you one question here. So most of these patients are on beta blocker, like metoprolol or carvedilol or something like that. Why not put these patients on calcium channel blocker, which will do both kind of beta blocker effect, heart failure, and also will do some sort of pulmonary vasodilator? Is there a thought process of giving these patients calcium channel blocker rather than beta blocker, or both?
Absolutely no. Big no.
Big no.
The reason is calcium channel blockers, except probably amlodipine, which are shown in PRAISE trial, are uniformly negative inotropic agents. And the data about cilindipine, I am not sure. At most, it may be neutral like amlodipine. But mind you, even amlodipine trial, if I remember well, only the PRAISE trial, which is published somewhere in 98 or 99, has shown that. But routinely, if at all, even the guidelines say, if at all you want to give any calcium channel blocker to a patient with left ventricular dysfunction, it has to be amlodipine and nothing else. That too, in a patient who has already, where you hit the ceiling doses of ACE inhibitors or ARBs and nowadays ARNI, beta blockers, and still the blood pressure is high, in those patients, you make a concession and give amlodipine. So this patient is nowhere there from the perspective of the left ventricular dysfunction. Now, calcium channel blockers in pulmonary hypertension is a quote unquote should be avoided as much as possible. The only role for calcium channel blockers in pulmonary hypertension is only group 1 pulmonary hypertension, not in any other group, number one. Number two, you have to document the reversibility of the pulmonary vasculature, that it is not a structural fixed changes, but it is the vasospastic changes which are reversible with active vasodilator agents. Typically, in a patient who is not in heart failure, who is in functional class 1 or 2, we take them to the lab, do a right heart catheterization, leave the catheter in the pulmonary artery, continuously monitor the pulmonary artery pressures and also cardiac output, or at least we should be able to measure cardiac output immediately with a thermodilution catheter. And you give short-acting pulmonary vasodilators. A most ideal agent is nitric oxide, about 10 to 20 ppm, or adenosine, starting from 50 micrograms per kg per minute up to 350 micrograms per kg per minute, or we give prostanoids, or inhaled or intravenous prostanoids, and you have to demonstrate that the pulmonary artery pressure drops, mean pressure drops by more than 10%, at least to a value less than 40 millimeters of mercury. And these patients who form about 10% of the subset of acute, not acute, group 1 pulmonary hypertension, typically idiopathic pulmonary arterial hypertension, they form only 10%, typically more often in children up to 35%. In these patients, if you demonstrate positive response to acute vasodilator challenge, then only you give calcium channel blockers. Even among these patients, not all of them will have sustained effect. So you have to periodically keep looking at them and see whether the effect is sustained or not. Otherwise, it is not appropriate to give calcium channel blockers for any patient with pulmonary hypertension. Typically, we don't even think of calcium channel blockers in group 2, 3, 4, 5 pulmonary hypertension, only a subset of group 1 pulmonary arterial hypertension patients. So, especially this patient has got mild RV dysfunction, all the more reason we should not give calcium channel blockers. And mind you, Sometimes giving inappropriately the calcium channel blockers, the patient may crash. So you should never give. And also, all the drugs which are found to be very helpful in patients with left ventricular dysfunction, typically beta blockers. Beta blockers in the presence of right ventricular dysfunction, there is some data to show that it is not that particularly helpful. Once the RV dysfunction starts, patient may not do same as given typically to isolated left ventricular dysfunction, or typically isolated right ventricular dysfunction in congenital heart disease, they may not do as well as you expect them to do with reference to left ventricular dysfunction. Only morning, incidentally, only morning I was discussing with Dr. Balakrishna, CT surgeon, is a really great man. He was pointing out that in their analysis, even Vimada doesn't do well if you give to the patient with significant right ventricular dysfunction. So, I mean, this is not a established published rule, it is observations. So, you should understand right ventricular dysfunction and left ventricular dysfunction are different ball games. And probably because this patient has got significant left ventricular dysfunction, the whole pathology is on the left side, you should go ahead and give ACE inhibitors, HARNI, or beta blockers, and all the typical guideline mandated therapy, but definitely no calcium channel blockers.
Thank you so much, sir. Raghu, sir, please go ahead. Raghu, sir, I'm going to unmute you.
Thanks, Anup. Shastry, that was a wonderful talk on pulmonary hypertension. When you made it very concise, it was actually like reading a review in a journal or a textbook. Well, with regard pertinent to this case, I know that both Shastri and Praneeth have taught of right heart cath, and I agree that if you really want to classify pulmonary hypertension, that should be done. But given the history of this patient, a history of an MI, a surgery, a CABG, and a valve replacement, I would first probably do a transesophageal echo in him to rule out a paravalvular leak, which is often masked by the acoustic interference of the prosthetic valve. Anup, I do not remember whether you mentioned it to be a bioprosthetic valve or a metallic valve.
Sir, it's a metallic valve. It's a metallic
so
valve, and we have not done a TE on him.
And you have done a TE on him?
We have not.
I would initially, before even a right heart cath, I would insist on a transesophageal echo for two reasons. One is to pick up an obscure MR which may be severe. The second is when you have a metallic valve, the usual parameters of diastolic dysfunction are very difficult to elicit. Now, when you have an elderly person with pulmonary hypertension, diastolic dysfunction can be a very important reason for the development of pulmonary hypertension. I have seen quite a few patients who have restrictive filling pattern, stiff ventricles, who have very severe pulmonary hypertension. And this happens even in restrictive cardiomyopathies. In fact, in one of my patients whom I sent to Dr. Shastry, he did a cath and said it was restrictive cardiomyopathy, but my own clinical judgment and my serial echocardiograms disproved the restrictive cardiomyopathy. He had only a restrictive filling pattern, but not a restrictive cardiomyopathy. An MRI also did not suggest a restrictive cardiomyopathy. And so diastolic dysfunction is an important aspect to be looked at. Often it is not glossed over, and that may also be a cause for severe pulmonary hypertension. Now, when you have a metallic valve, how do you look at diastolic dysfunction? Now, the usual mitral A and E are no longer valid. IVRT is no longer valid because the annulus is taken away by the prosthetic sewing ring. So how else do you assess? The pulmonary vein remains the only way of assessing the diastolic function. And if you have a markedly elevated D wave, you know that the diastolic function is likely to be abnormal. The low EF, higher EDP may be contributing further to the mean LA pressure, thereby the pulmonary capillary wedge pressure. Of course, if you do a cardiac cath, just like Dr. Shastry pointed out, the pulmonary arterial to the wedge gradient, if it is less than 10, then you know that you're dealing only with type 2 pulmonary hypertension. But if the gradient is much greater, then you know that you're dealing with possibly other factors apart from the left heart factors. So these are some things that I thought I would just raise just in this case. Having said that, if you give me another minute, Anup, I'd like to recount that my own brother-in-law, who had at the age of 46 an anterior MI, was thrombolized and subsequently underwent a bypass and was doing very well till 2007 when he had another small inferior MI. He started developing severe pulmonary hypertension in 2010. In 2011, he underwent a PTCA of the Lima LAD anastomosis, and I was hoping that would relieve his pulmonary hypertension, but it did not. He had very mild LV dysfunction. He had no significant MR. He had no valve replacement, and yet he developed very severe pulmonary hypertension. He went to University of Los Angeles, where Teresa Marcos did a cardiac cath on my request, and they couldn't prove anything. And ultimately, they took the waste paper diagnosis of multifactorial pulmonary hypertension. In the interim period, he had any number of evaluations to rule out both perfusion scanning and CT pulmonary angiogram. He had an MRI, he had a PET scan to rule out myocardial disease. And despite all this, his pulmonary arterial hypertension was inexorably becoming severe. Ultimately, I had to start him on sildenafil, and he lived on. He passed away last year. He lived on for 5 years with sildenafil, apart from the other treatment like diuretics and other things. So I have seen quite a few patients when I am doing echo of patients who've had an MI, or patients with aortic stenosis who have pulmonary hypertension out of proportion to what you normally expect. And of course, I don't have cardiac catheterization data to back up for all these patients, but though not common, it is not so infrequent either. Thank you.
Perfect. Thank you so much, sir. I think that the last patient encounter that you shared, this just goes on to prove the point that, I mean, not only that we don't understand this pathology that well, the pathology itself is so complicated, particularly with all the multiple factors involved, that sometimes even to the best of our efforts, we are not able to just pinpoint how to treat or what not to do. So anyway, with the theme going on, there is a question that came from the audience. I'm just going to read it out, and maybe I'll have Dr. Shastry give his opinion, and then I'll have others give his opinion as well. I have very limited information about this, so I'll just read out. A middle-aged female with connective tissue disease and a history of pulmonary hypertension. She's admitted right now with sepsis and renal shutdown, intubated. And her PA pressures are, I'm assuming, to be very high. But she's in shock. So how can we treat this pulmonary hypertension? Because this is being counterproductive right now. I'm sure her systemic pressures are low. So can we do something to treat her pulmonary hypertension right now? And this is also a clinical scenario that happens so commonly to us. So Dr. Shastry, can you help us? How is there a way we can treat this patient?
Well, it's definitely a difficult situation. The pulmonary vasodilator, sildenafil especially, is not a very hypotensive agent, especially if the hypotension is because of the severe pulmonary hypertension, severe RV dysfunction, or with or without severe RV dysfunction and fixed cardiac output. I'll tell you as an anecdote, I'll give you one example. Way back when we were starting sildenafil, maybe year 2000, one young girl was there, 12-year-old, from Mahbubnagar, Muslim girl. She came with severe pulmonary hypertension. Her father was a teacher. So sildenafil was not approved, not even off-label. So that, some of you know that I was the first one to do the study. I had a stock of samples. I had not yet started a formal study, but I was giving it off-label, closely monitoring the patient's parameters. Now, father was a teacher. When I explained that this is off-label and not approved, and because I have to be very careful, because they come to know this is for erectile dysfunction, they will jump on me, pounce on me. So he listened to me and said, no, sir, I don't want any experimental medicine. I said, fine. Then after a few days, He came, the child was very sick. Very incidentally, unfortunately, I was on duty in Nampally. So we admitted the patient, what is now presently MICU 2. And the patient was sinking. Blood pressure went down to 80 millimeters of mercury. Heart rate was 110, 120. I was on night duty, watching, just helpless. Then again, I asked him, see, she's not going to make it. Do you want me to try? He understood the situation. He said, okay, sir, go ahead and try. So I called the security, got my room open, and took out the, gave it, and sat with the patient. And believe me or not, the heart rate gradually came down from 125, 130, and the pressure improved from 80 to 100, and patient became all right. So what I mean to say, this case drives the point. If the hypotension is because of the fixed cardiac output from the right ventricular pulmonary circulation, pulmonary hypertension, you go ahead and give, nothing happens to the patient. But in the case scenario that you gave, a connective tissue disease patient with sepsis and what else? Is it
Renal shutdown. Probably,
yeah,
probably.
renal shutdown is not an issue. Renal shutdown can be because of the low hypotension, low pressure, and sepsis. You have to understand, is it really because of sepsis? Sepsis, you have some parameters. You got very high procalcitonin and hemodynamically wide pulse pressure, very low diastolic pressure. Now, even then, I don't think pulmonary hypertension is a contraindication. I mean, pulmonary vasodilators are a real contraindication. If you can demonstrate that pulmonary systolic pressure is really high and there is RV dysfunction, which is contributing to the hypotensive state. I'm sorry, again, I'll give another anecdote. This is important to understand how we practice. For the clinical trial, we have taken a patient with pulmonary hypertension. Now, this girl is very sick. She is about 20-year-old, and we have to have a right heart catheterization. And we have to demonstrate by CT pulmonary angiogram that it is not thromboembolic pulmonary hypertension. She's a part of clinical trial. So we admitted the patient. Those days, even I was inexperienced. In the sense, you'll understand why I say that. I sent the patient for CT pulmonary angiogram. It was done somewhere late in the afternoon, about 3:34. So I went home. Then, fortunately for me, nursing station from 219, nurse called me. She was in 220. Nurse called me and said, sir, the patient's pressure is falling. It is 80 millimeters. Then I didn't know what to do. I requested the DMO to go. We shifted the patient to ICCU. Then she's not doing well. Pressures are slowly coming down. She's becoming restless, tachycardia. For some reason, I got a doubt and got a procalcitonin done. And believe me, it is the patient developed fever also. And believe me, it is more than 100. I said, come on, forget about the trial. We started the patient on pulmonary vasodilators and straight away started meropenem. I was not sure if it is a false positive, but anyhow, I started meropenem because I couldn't afford to lose the patient and started sildenafil. And gradually, patient made recovery. And without including in the clinical trial, we dropped the patient and sent her home. The reason why I'm saying I was inexperienced, then we reviewed the process of how the CT pulmonary angiogram was done. I sent the cath lab nurses to observe what is the protocol in CT pulmonary angiogram. They have absolutely no concept about aseptic precautions. The syringes, catheters, the way the dye is loaded, it's handled was terrible. So later on, we taught them. Obviously, the sepsis has come from the CT pulmonary angiogram, syringe injection of the contrast and all that. Now, what I mean to say, even in the presence of sepsis, when the patient is slipping into shock, I went ahead and gave sildenafil, and that patient survived. Both the patients, mind you, both in hypotension, one due to severe right ventricular dysfunction because of severe pulmonary hypertension, and second, additionally having septic shock, you can give, provided you are very sure that the patient pulmonary artery systolic pressure is pretty high and it is not a falsely assumed PA systolic pressure. So sildenafil is not a big problem. Probably ambrisentan or endothelin receptor antagonists, I will hesitate because they have much more arterial vasodilatatory action. And if I remember well, ambrisentan originally came as a antihypertensive agent than these androgen receptor antagonists came as antihypertensive agents than pulmonary vasodilators. I hope that answers the question.
I just have a follow-up question on that. When you start sildenafil on these borderline pressure patients, what dose typically you start with? And once you start, how soon you expect a positive response to come in case if it does come?
See, the typical dose we can give comfortably 20 milligrams, 20 millimeters of, 20 milligrams of sildenafil. That is the FDA approved dose, and that is enough dose. Now, you should not give if the patient is getting nitrates. That is very, very important. If the patient is getting concomitant nitrates, to add sildenafil is disastrous. So we always educate our patients who are on sildenafil not to be on nitrates. At least there should be 24-48 hours gap should be there. And if the hypotension is because of the pulmonary hypertension, you within 1 to 2 hours see that patient turns around. The first example I gave, I was sitting with the patient. We started exactly when the morning azan came. That must be 5 o'clock in the morning, 5:15. That's when I gave the medicine. By 7:15, the patient's pressures were 100 and heart rate came down from 130 to 100 or less. So within 2 hours, you get it. Sildenafil absorbs very well and acts very fast.
And that you are okay with even if let's say systolic pressure is 90 or less, you are okay giving 20, or you try 10 first and then give 20?
I'm okay with 20 milligrams.
You're okay with 20. Okay, perfect. Else has any other questions, thoughts on this case, or as a general about pulmonary hypertension? There is one more question here, sir. I'm just going to read it.
Dr. Anup, can I add to this discussion?
Yes, sir. Yes, sir. Please go ahead.
Yeah, this patient whom you're talking about with a renal shutdown and pulmonary hypertension, and hypotension, probably if there's a renal failure adding to metabolic acidosis and hypotension, that patient requires dialysis. And then renal failure itself could be adding to some part of the pulmonary hypertension per se.
Certainly, sir. Certainly. Shastry, sir, there is one question from the audience. I'll just put it up. I think you will be the only person knowing this answer because I have no idea. The question is, what has been the experience of lung transplant in burned out pulmonary hypertension case, primary pulmonary hypertension, of course, because the person who asked the question, he shares his experience saying that 2 of his patients underwent transplant. One of them survived, younger female, the other one died, which is slightly older male. So do you have any first-hand experience of lung transplantation in primary pulmonary hypertension? Shastry, sir.
Yeah, I did refer patients. Prashant is lucky that he had 2 patients, but only one of my patients underwent lung transplant, and fortunately she is doing well. And Apollo Chennai and Narayan Hrudayalaya Bangalore, they do more often. I think even Chennai Global Hospital, where Sandeep Patawar was doing earlier, they were doing many cases. They had much more experience with pulmonary hypertension lung transplant. But the situation is not that bad. Definitely lung transplant, bilateral lung transplant, heart and lung transplant, they have more morbidity, mortality compared to the routine heart transplant. Even in the Philadelphia, the 5-year mortality is, 5-year survival rate is only 60%. That is a little older figure, but now it may be better. But conditional survival after first year is supposed to be good. Most of the problems with the heart or lung transplant, they typically occur in the first year. So if they survive the first year, we almost expect 5-year survivals of more than 80-90% even in lung transplant for pulmonary hypertension. First 1 year is critical. And one important aspect is what Dr. Sundar keeps mentioning in his lectures from Apollo Chennai. You should select a proper window period. It should not be too early where, the morbidity, mortality risk of transplant outweighs the actual risk due to pulmonary hypertension. Or it should not be too sick, dying patient with multi-organ dysfunction, liver dysfunction, renal failure, and thrombocytopenia, and frailty, malnutrition. Even that patient won't do well. So for that purpose, we have got Reveal 2 score, which is based on multiple factors, which will give you more or less precisely what is the expected survival rate. And accordingly, you can pick up the patients. So patient selection is very important in the post-transplant survival. And remind me, Anup, I have to add to something what Dr. Raghu says. Probably I will add it later.
Thank you so much, sir. Anybody has got any questions? This is your time. You can either unmute yourself.
Anup,
Yes, Raghu, sir.
if you're
Please
not
go.
tired of my voice, can I?
Not at all, sir. Not at all. Please go ahead.
I raised my hand and I was waiting for you to respond, but then I thought I'll
Sure. Please, sir. Go ahead.
unmute
Please go ahead.
myself. No,
Please go ahead.
only thing I wanted to add was that in dire cases in patients where lung transplant is not easily available and all that, nowadays they are doing a trial. They are doing a trial on septostomy and an intranatal device to help right to left shunt occur, and thereby bring down the pulmonary hypertension and improve the output a bit. This is still in its formative stage. I think there is a trial undergoing. I saw a video once on WOMED of about 8 to 10 cases being treated this way. I don't know whether Dr. Shastry is keeping track of this, but this may also in future become a modality in very severe patients who have stopped responding to medications and the possibility of a lung transplant is not immediately available.
Sir,
you want me to respond, Anup?
Yes, sir. I'll just put a comment because this was my question for Shastri sir towards the session. Occlutech is doing a trial that I know, but they are doing trial for left heart cath. They have a device as a septostomy device. They are doing for left heart. But Shastri sir, please tell us your impression of use of that device for pulmonary hypertension.
Yeah, this is used in both. I don't know exactly the device name. Is the same device or different, but the pathophysiology understanding or the mechanism is same. It is used both in cases where you have got both right atrial hypertension as well as left atrial hypertension. Now, what Dr. Raghu was mentioning, first coming to the primary idiopathic pulmonary hypertension, the perinatal septostomy, especially with a blade and graded perinatal septostomy, is definitely helpful. The initial experience came from Mexico, and we have to be very careful in selecting the patients. The unselected patients, mortality can be 1 month mortality can be almost as high as 20 to 25%, and on-table mortality can be almost 5-10%. It should not be done in advanced cases. It should not be done when the systemic arterial saturation is less than 90%. It should not be done when the right atrial pressure is more than 20 millimeters of mercury. It should not be done when the pulmonary vascular resistance is more than 55 Wood units. And definitely should not be done in dying sick patients. So patient selection is very important because typically after doing a perinatal septostomy, we expect a fall in systemic arterial saturation by 10%. So up to, you start with a 90%, the patient saturation drops to less than 80%, and the patient will have severe hypoxia leading to death. So one has to be very careful, closely monitoring the left ventricular end diastolic pressure and systemic saturation. It has to be done. Along with Nageswara, I have done about 3 cases, and one of the patients is doing very well. One child died. Now, the device that Dr. Raghu was talking about is an extension of that. The perinatal septostomy tends to recoil and close over a period of time. And in many experience centers, they do second time or even third time. To prevent that, the company has come out with a device which will keep it patent. So pathophysiologically, there is no difference between the simple perinatal septostomy and the device. We are not part of the study. Shivakumar from Triple M is part of the study. He has, I think, done 35 cases or something. He keeps projecting his data, which is very, very impressive. The device is pretty expensive, I think more than 3.5 lakhs or something, but I could never understand how we could achieve so good results in the similar patients. I don't know. Basically, somehow we could never find right patients, either they are too sick or not too sick. That is one thing about the pulmonary hypertension. Now, coming to the left atrial hypertension, heart failure with preserved ejection fraction, some of them have disproportionate pulmonary hypertension, some of them have disproportionate left atrial hypertension. Of all the treatments, this device, after atrial septostomy with a shunt device, is the only one which showed some quality of life improvement at the end of 1 year, but final jury is not out. Probably we require more studies. It doesn't seem to alter the mortality, but morbidity and the quality of life symptom status are better. There are 2 different indications. One is when the heart failure with preserved ejection fraction when left atrial hypertension is there. Second, what Dr. Raghu was saying, idiopathic or pulmonary arterial hypertension with when the severe right atrial hypertension and fixed cardiac output are there.
Thank you so much, sir. So that Occlutech device, it looks just like that ASD device, very similar. And the deployment is also very similar, except that rather than a complete ring, it has got a hole in between. So literally, you create a septostomy, and then you do an ASD closure. With the only difference being this ASD closure device will have a hole in between. So it will have wings to attach to the septum, and then hole. And as Dr. Shastry said, that the jury is still out. We don't know how much of it works, but there are certain, unit level experiences. I personally don't have any experience for that. Dr. Shastry, would you like to shed light on some of your previous research work? I know there was some research where FDA was involved with pulmonary hypertension. What was that? I believe that some FDA team had to was involved with you.
Is it really required for this academic discussion? Anyhow, I'll try to put it briefly.
Yeah, I just thought people would know.
Yeah, to start the story, Dr. Kedarnath, I borrowed NEJM from him. So I took it home and wanted to read some particular article. Though I was interested in pulmonary hypertension at the time and collecting natural history of patients, I didn't do any particular research work except registry. Then it so happened morning I wanted to take the NEJM back to back to the hospital and give it to Kedarnath. The NEJM, thin papers, it is lying in the drawing room, and because of the fan, it was going around. The pages were flipping. My wife saw that and said, "Why did you bring NEJM? Oh, is it because of pulmonary hypertension, sildenafil?" There is a letter to the editor by one Prasad from London about the anecdotal and use of off-label use of sildenafil pulmonary hypertension. The result was very impressive. I was so excited. I came to Nampally and showed it to Dr. Somraju. Then all of us were excited, Raghav and all. We had a discussion at the cath lab there area. Then Somraju said, somebody gave me a lot of samples of sildenafil. What do I do with that? You use it for your patients and study. So he gave me so many tablets of sildenafil. Because I had the registry, I called all the patients and started giving it to patients. Some of these things, I'm sorry, this is elaborate, but we'll tell you some of the insights into the research, how it happens. Then Dr. Samraju has given me, so I started giving it to my patients. I called all of them back and started giving it. And even then I was very careless. I know 6-minute walk test has to be done, and there used to be a nurse in same AMC area, a little more smarter than others. I used to send the patient to her and ask her to do a 6-minute walk test. Totally unscientific way in the second floor corridor between the 290 nursing station. So that nurse was smart because she maintained a record of these things. One day suddenly I chanced, I saw that. I said, come on, a nurse is maintaining a record and I am not maintaining record. And from then on, I diligently maintained records, pre and post sildenafil, 6-minute walk test. Then I found it very impressive results, which was sent to Indian Heart Journal. Actually, this was selected for Young Investigator Award. But Gambhir one day before called me and told me this is going to be published in Indian Heart Journal, so I can't publish it. You can't present it in the Investigator Award session. Anyhow, it is published in Indian Heart Journal, but I wanted to send it as more data to International Journal of Cardiology. Then International Journal of Cardiology said, you have done 6-minute walk test, which is of no value, which is wrong actually. There may be problems in methodology. So Narasimhan said they rejected International Journal of Cardiology. Narasimhan said, why don't you do a randomized trial? So there is Series Pharmaceuticals. They are the bulk manufacturers of the sildenafil. So there is a pharmacist there who is, I know he's Lakshinarayana. He's incidentally had some peripheral vascular disease and he has some symptoms. Dr. Somraju and Narasimhan were treating, and Somraju sent him to me for sildenafil. He was very happy. He said, sir, I want to give you any amount of sildenafil that you want, both active medication and placebo. So myself and Narasimhan thought over. We thought we'll do a study. I was so idiotic at the time. I thought 6-minute walk test is probably not a right thing to do. I didn't even read the literature properly. I thought, okay, let me put the patients on Norton protocol on treadmill and see. Then Narasimhan said, why don't you do a crossover study? That means you give a placebo or active drug initially. We designed in such a way, randomly, blindly, we give active drug or placebo to these patients, then cross them over to other active drug. So each patient is his own control. So first 6 weeks they got the active drug or placebo, and next 6 weeks they got active drug or placebo. We monitor the quality of life. We looked at the echocardiogram. I used to do all echoes, including PA pressures and cardiac output and PVR, everything, pulmonary hemodynamics on echo, periodically every 2 weeks. And used to do this one, Norton test at the end of 6 weeks, Norton protocol treadmill at the end of 6 weeks, and quality of life. So this time we are more diligent. We collected all the data and sent to Jack, and it was immediately accepted and published. And that is the first randomized control trial, double-blind control trial of sildenafil in pulmonary hypertension. So Pfizer just then started the super trial, which is the randomized double-blind multi-center trial of sildenafil in many centers. So in fact, FDA asked the Pfizer to look at my data and come out and how the data is, original data. So fortunately, by the time I got exposed to, by the time the study is done and published, there's one pharmacologist from Reddy Labs in those days. He helped me design the project protocol. That is one of the important things. But for his guidance, probably I wouldn't have applied for DCGI. So he helped me made protocol, and he helped me send it to DCGI for permission. Now, another interesting story is we have to get DCGI permission. You know how difficult it is. Then one of the off-label patients was a relative of Dr. R.P. Raju. He used to be our medical director in Nampalli. Those days only Nampalli was the main hospital. R.P. Raju was there. He's a medical oncologist. His nephew or somebody relative, young boy, was treated with pulmonary hypertension, and to my fortune, that boy has a dramatic relief. His PA pressures, actually I did cath 2 times. His PA systolic pressure dropped by 50%, one of the very dramatic results. So he was so happy. When he came to know about the study and all the DCGI permission, he introduced me to, what is his name, an IAS officer from Rajahmundry, Yugandhar or somebody, who lives in that Sagar colony in Banjara Hills. He was PMO, one of the senior IAS officers in PMO. So he gave introduction letter to me, and I went to his house and requested him. He took the details, and within 2 days I got the permission. This is so helpful because, Dr. Bharani, what is his name, from Indore, Aranya should graduate, called cardiologist. I'm not getting the correct name. He also did study. He didn't take the DCGI permission. Poor fellow has to face legal action. Court has warned him and sent him. So whenever you are doing clinical trials like this, it's very important to take the government permission, take the informed consent forms. The pharmacologist from Reddy Labs helped me. So many people helped me. And with that, I could do that study, which was recognized by FDA. FDA, in fact, sent Pfizer team to the site. They looked at all the data and they are satisfied, and I don't know what they did. So this is in a nutshell about the research study that I did.
Perfect. And sir, since we are towards the end of the session, it's already late. Let me first take some questions. Kota Raghavendra, your hand is up. Do you have any question? Please unmute yourself. Raghavendra, I can't see you now. Raghavendra, you are unmuted. Please ask your question. Okay, he probably does not have any question. Shastry sir, you told me to remind you that you wanted to add something to Dr. Raghu's point towards the end of it.
Yeah, Dr. Raghu sir, the echocardiogram is very, very important. We can't emphasize more. As you gave, I heard your talk 2-3 times. The whole hemodynamics, though may not be very accurate, but by and large in many patients, you can have a very good idea about the echocardiographic evaluation in pulmonary hypertension. I mentioned briefly, it is a big topic by itself, that echocardiography you can differentiate between the pre-capillary pulmonary hypertension and post-capillary pulmonary hypertension. And in a patient like this, there can be combined pre and post-capillary pulmonary hypertension. Now, though we mentioned about right heart cath, it is not very mandatory in a patient like this, because it, in all probability, this patient will have pre and post capillary pulmonary hypertension combined. Now, why do you want to do any diagnostic test? It should be effective in giving some treatment. Now, this particular patient in our case example, what Dr. Anup has presented, is a 71-year-old male with an ejection fraction of 30-35% with a prosthetic mitral valve and severe tricuspid regurgitation. Now, what is going to change you once you do a right heart cath? For sure, you will find post-capillary pulmonary hypertension. The pulmonary capillary blood pressure, you expect it to be high. And it's possible that he also has a pre-capillary pulmonary hypertension, maybe genetically predisposed and has got a additional pre-capillary pulmonary hypertension. So most likely has pre and post-capillary hypertension. So now the million-dollar question, which I wish you had time because we is, how do you treat these patients? That is actually the crux of the problem. Now, suppose you demonstrate in this patient pre and post-capillary pulmonary hypertension. Will you give this patient? It is very unlikely as isolated pre-capillary hypertension, isn't it? With the LV dysfunction and mitral valve replacement clinical scenario, it is very unlikely. So he may be having additional pre-capillary pulmonary hypertension. So diastolic pressure gradient of say 10 millimeters, say a PA mean pressure of 45 millimeters of mercury. Do we give this patient sildenafil? Do you give this patient ambrisentan, bosentan? No. That's very important to understand. In most of the clinical trials which have done, the pulmonary vasodilators, which can be grouped as PDE5 inhibitors, endothelin receptor antagonists, prostanoids, or recent soluble guanylate cyclase stimulants, none of them has shown survival benefit. In fact, 2 years ago, there is a meta-analysis which has clearly shown in European Respiratory Journal, it has published, in almost all the trials where specific pulmonary vasodilators are given in patients with left heart failure, there is increased mortality, period. Only PDE5 inhibitors have been shown to be beneficial in some patients. In single institutional studies, in uncontrolled studies or poorly designed studies, they have improved quality of life but did not improve the quantity of life. So, because this patient may be having pre-capillary pulmonary hypertension also, we should not give pulmonary vasodilators because that may be harmful to the patient. Now the question comes, how do you treat this patient with severe LV dysfunction? The treatment is, if the patient is, you should think of either LVAD, or if after doing a right heart cath, you should do either consider as an LVAD or heart transplant. You do a right heart cath mostly to assess further treatment whether this patient requires a left ventricular assist device or heart transplant. So for that, you have to have more diligent right heart cath study. I thought of sharing one article. I think probably I'll put it in the group. The nowadays right heart cath study is not just measuring the pulmonary artery wedge pressure, cardiac output, and PVR. You have to get some more indices like right ventricular stroke index, pulmonary artery pulsatility index. These are the factors which will tell you what is, apart from what is the pulmonary vascular resistance, whether the candidate is a candidate for left ventricular assist device. Up to a PVR of less than 3 or maybe 4, you can think of heart transplant. As the PVR increases more than 4, though some people do up to 5, the heart transplant is going to be a problem. Now, up to a PVR of 8, you can think of left ventricular assist device, provided you have got a load-independent indices of the pulmonary hypertension, which will tell you one such thing will be ideally should have a pressure volume loops of the right ventricle, which is not practical, but pulmonary artery pulsatility index and right ventricular stroke work index will tell you whether the right ventricle will cope up with post-LVAD situation. So, for a routine diagnostic management and pharmacological management, probably you don't require right heart catheterization. In all probability, patient will have a combined pre and post capillary pulmonary hypertension, which is not going to change the treatment unless you are thinking of a heart transplant or LVAD. So I urge all the, our generation is older, you people youngsters, the younger generation, especially exam going students, should know what more to gain from right heart cath rather than mere, what I mentioned earlier, pulmonary capillary wedge pressure, PVR and cardiac output. Thank you. We can discuss endless, but I think we have to stop somewhere. Thank you.
Dr. Rajesh, your hand was up. Did you have any question or comment? Dr. Rajesh Kalyankar, I am unmuting you. In fact, I'm not able to unmute you for some reason. Dr. Rajesh, please go ahead. Dr. Rajesh, we are not able to hear you. You have to be a bit louder. Your audio is very faint. Yeah, your audio is very faint. Can you please get close to mic or speak louder? No, we are not able to hear you. I'm sorry. Would you mind just typing your question? I will read it. I will read it out aloud. We are not able to hear you. I'm sorry. Kota Raghavendra, do you have any question? Please unmute yourself. Raghavendra, go ahead. Okay, I'm not able to hear you as well. I don't know why, if there is some audio issue or whatnot. I hope my voice is clear to everybody. It's 8:44 now. If you have any questions, please type it. If I'm not able to hear you, either now or offline, I will make sure your question is answered. Praveen, your hand is up. This is the last question we are going to take. It's 8:44. Praveen Nagula, please go ahead.
Sir, good evening, sir. Sir, I have a patient who is 21-year male. He has a large VSD and he had Eisenmenger syndrome. He was kept on Bosentan and he had intermittent right heart failure and had liver enzymes raised. So for that, Bosentan was stopped. And later he was kept on sildenafil, 50 mg BD. He was not responsive, sir. Any other treatment can be given, sir? He was on follow-up at this time.
See, Praveen, it is generally uncommon to see right heart failure and liver enzyme elevation in a 21-year-old VSD Eisenmenger. It's possible, but uncommon. That is number one. So look for other factors. Now, there must be Eisenmenger VSD. They behave like any other idiopathic pulmonary arterial hypertension, group 1 patients. So for some reason, you can't give Bosentan, especially because of the liver enzyme problem. You can definitely give ambrisentan and macitentan, which have absolutely no problem with the liver enzyme. So you can straight away put the patient. I would suggest you to start him on macitentan. There are a couple of brands available. You can give 10 milligrams once a day, practically devoid of side effects, except minor non-specific side effects. You can give 10 milligrams once a day. And don't stop with one drug. You can give sildenafil 20 milligrams three times a day, or tadalafil 20 milligrams twice a day. You go ahead and give upfront combination therapy. That is how it should be treated, especially in a sick patient like this. And probably in near future, we'll be getting Selexipag, another wonderful drug that will practically solve many of the problems. So you can wait for that. So Eisenmenger, for all practical purposes, behaves like idiopathic pulmonary arterial hypertension so far as the response to treatment is concerned. If the patient is already having right heart failure, I think you should, if the patient can afford, you should consider heart-lung transplantation. Thank you.
Okay, sir. Actually, we have sent him for that GM1 enrollment. Thank you.
Perfect. It's 8:46. We have few questions coming up. If Dr. Shastry allows, maybe we can do another session of pulmonary hypertension where we can talk about maybe group 3 or group 4 pulmonary hypertension. few cases that we can get started with. But currently, I think we'll have to pause because we are certainly exceeding time. Praneeth, do you have any closing comments on this session? And then we'll have Dr. Shastri's final comments, and then we'll close. Praneeth?
Thank you, Dr. Shastri sir, for attending our huddle and sharing your thoughts. Your story was definitely inspiring. Thank you for sharing the story. It was very enlightening, a clarity of thought on pulmonary hypertension, how to approach and all. And I think most of us still have a lot of questions unanswered. The moment you read or hear, you feel that you have already learned about pulmonary hypertension, but when you actually face the patient, you are again blank. So these things definitely need more of discussion, and we would be very happy if you join us for a few more sessions so that we can keep sharing our cases and learn more. So thank you again for everyone to participate. This is from my end, Anup.
Sir, comments for this session and maybe potentially doing another session later on.
Yeah, thank you very much again for inviting me, and I have no problem. I love to share the knowledge, and definitely I can participate in another session. Only request is all the trainees and those who passed, right heart catheterization, please learn how to do it. Cardiology practice is not just coronary interventions or nowadays structural intervention. Even for structural interventions, you have to have concept of cardiac hemodynamics, which I find many doctors in training are lacking. Whenever I do right heart catheterization, please join and try to learn what can be done. Even I am learning now. It is a never-ending process. I'll share with you the hemodynamics of one of the patients for heart transplant, potential heart transplant, how the serial right heart pressures have changed. I'll post it in the WhatsApp group, and also the articles. Those who are interested can read. What else we can learn from right heart cath? So, Anup, I'm ready to join your program whenever you want me. Thank you.
Sir, thank you so much. And just continuing with what you said, I think this idea is going to be very practical. Every attendee of this session, if you have any case experience of pulmonary hypertension, where you have got some information, some right heart cath, how did you make a diagnosis? How did you reach to a decision? What was your rationale? In a case summary format, I would love to have that care, or we have in the audience, we have got doctors from outside care as well. Please email me. What I will do is I will create an email link of all the attendees who were here today, and we'll share our thoughts on the email thread. So if you have any case which has got a near complete story where you have came to a conclusion, maybe took some hints from today's session, please share it with me. We will make it a thread, and that way pulmonary hypertension will be an ongoing learning for us. And so that next time when we have Dr. Shastri, we can probably take some of the cues from those thread as well, and have our discussion very precise. So I think that is definitely going to add value to our discussion. Thank you, Dr. Shastri, for being with us. We will soon have you again, and everybody else for joining. Any other question which was not answered, please email me. I will make sure that we get it answered. Every huddle is recorded, so if anybody needs a recording session, just email it to me or text me, and I will be happy to share that. We are 21 minutes out of this, and I wish you all good night. Take care, and we'll see you next time. Thank you all.